Hello, viewers. Welcome to this episode of Healthy India. All of us have experienced at some time in our lives some discomfort, some gas, some acidity in the upper part of our abdomen. This common condition can be just a minor symptom, or it can be a sign of severe disease sometimes. It can happen if you miss a meal, prolonged gaps, or it can happen if you eat a heavy meal. So to understand all about acidity or acid reflux disease, to answer your questions today, we have two distinguished panelists with us. We have Professor Gourdas Choudhuri, who's currently the chairman of Gastroenterology and Hepatobiliary Sciences at the Fortis Memorial Research Institute. And we have Dr. A.S. Puri, who is the vice chairman of Gastroenterology and Hepatobiliary Sciences at the Medanta Hospital in Gurugram. Now, both these gentlemen have very distinguished academic careers behind them. Let's talk to you, Dr. Choudhuri. You know, people talk about acidity, and it's something to do with a valve at the lower end of the food pipe. You want to explain what this whole mechanism is?
Yeah, so thank you, Dr. Ambrish. You know, the problem of acidity is that acid, that's hydrochloric acid, is produced in the stomach. And that is how nature decided that where it should be produced. It's normally good for digestion, but when it's either in excess or it causes some trouble, then, you know, it can cause a lot of symptoms. And one of the ones which you are referring to and the topic of our discussion is called gastroesophageal reflux disease. So in this, what happens is that the acid and the food in the stomach tends to climb up into the food pipe. And that's a very sensitive part of the GI tract. And that is where acid should not be, because this valve at the lower end of the food pipe and between the food pipe and the stomach, it's a one-way valve. So the food goes down, but the acid and food is not supposed to climb up. So when it climbs up into the food pipe, which is just behind the chest, so that causes a distressing symptom called heartburn. And the term is heartburn because it's close to where the heart is and it's a burning sensation. And that's a very, very typical symptom of what we call as gastroesophageal reflux disease. The other symptom, of course, is that in some, it may not be so much of burning, but they often feel there is a lot of, stale food or watery substance from the stomach regurgitating all the way up to the mouth, especially at night. So that is called water brash.
So Dr. Choudhuri, basically, आप हमको ये बता रहे हैं कि हमारा खाना जो फूड पाइप इसोफेगस से होकर नीचे जाता है पेट में, हमारे स्टमक में, वो अगर उल्टा रास्ता अपना ले और ऊपर आने लग जाए, जो एसिड हमारे खाने को डाइजेस्ट करने के लिए हमारे पेट में बनती है, वो अगर ऊपर आने लग जाए जहां उसे नहीं होना चाहिए, हमारे फूड पाइप में, गले में, तब इस कंडीशन को एसिड रिफ्लक्स disease कहते हैं. Very nicely explained, Dr. Choudhuri. Thank you. But, you know, Dr. Puri, there are a lot of symptoms attributed to acid reflux. You know, under the whole heading of acidity, people put in a lot of stuff. So what are the symptoms that we see typically? Some Dr. Choudhuri has pointed out. And sometimes these symptoms can be confused with heart symptoms. And we've seen that happen, that people both ways, people who had heart symptoms thought it was hyperacidity and got into, trouble, or other way around, people who were just had some acidity, panicked and, went to the cardiologist. How do you explain the symptoms and how to differentiate from cardiac symptoms? Dr. Puri, please.
Thank you, Dr. Ambrish, for the kind introduction earlier. And this is a very relevant question that you asked. So Dr. Choudhuri has already pointed out that the two dominant symptoms of GERD or reflux disease, or Gerd, if I may be using the term, is one, it causes the heartburn, second is water brash, and the third important symptom is pain. And this pain, because it occurs right behind the breastbone, it's sometimes confused with cardiac pain, because that's where you would get the pain of angina or coronary artery disease as well. So what would be the pointers towards either side? So first, if you are getting symptoms at rest, that means you're sitting down, you're sitting on your table doing some work, and you're getting after a meal, then it's more likely to be reflux disease. Whereas if it is because of effort, that you're climbing stairs or you're running, walking fast, doing some heavy work, and if you get symptoms at that time and the symptoms abate when you rest, then it's more likely to be cardiac. The second important point is if you're getting your symptoms immediately after meals. So you had some nice vada sambar, spicy food, and immediately after that, you start getting a pain soon after that. So that would point out that this is the reflux that is occurring. And the third, almost a giveaway, is that the pain in GERD remains localized to this area behind the breastbone. And it doesn't radiate anywhere, maybe a little into the neck. But if it starts going into your left arm, now that is against GERD. And that would tell you that this is probably a cardiac pain. And lastly, if you have if you're having a cardiac pain, angina or something, it is very often associated with sweating, with palpitations, and you feel that sense of impending doom. So these are in very broad categorizations.
Wonderful. Nice explanation, and a common problem that every physician faces almost every day in the OPD is this kind of dilemma. And of course, people face it, public faces it all the time because they're not sure when to go to the doctor, when not. But Dr. Choudhuri, acidity is a very common thing. Everyone has some little of acidity or discomfort. Is it really a disease? And when do we think of it as a disease?
There is really no scientific measure for that, in the sense that if a symptom bothers a person enough to go to a medical personnel and seek attention, it becomes a disorder or a disease, call it. And some of it depends to a large extent on a person's threshold of tolerance and how he perceives the symptom. To give you an example, if suppose somebody notices, and just to make things a little even balanced, Amarender talked about sambar and what was it? Chutney, did you? May I give the example of a chole bhature? So if suppose somebody has a lot of spicy, oily food for dinner, or every other day has a very light, very heavy dinner, and he gets reflux symptoms once in a while, say maybe once a month, he would possibly know that it's related to his meal. And, he may discard it or modify his methods, and that does not necessarily qualify to be a disease. If it becomes a very frequent symptom that troubles him, or there are other associated symptoms. And, just for simplicity, we talked about heartburn and water brash, but there are 2 or 3 other symptoms also. One is, at night, some people start coughing and choking because this food and the acid it climbs up into the throat and goes into the windpipe. Some people develop nocturnal asthma. So, they get breathlessness at night. These are also symptoms of reflux. So any of these which are troublesome enough to make the person very uncomfortable and seek medical attention becomes a disease. Now, the problem is that the measure of severity or discomfort is perceived by the patient, whereas the doctor, like us, for example, we'll put in an endoscope and we see are there ulcers in the food pipe that have happened or not, how loose is the valve, and so on and so forth. Interestingly, the correlation is not very good. So some people may have a lot of symptoms, and yet the endoscopy may turn out to be reasonably okay, just mild changes. Whereas with other people, the relative symptom intensity may be low, but when you put in a scope, you find that there can be quite a bit of ulcers, which we call as reflux ulcers or esophagitis. So that part is a little dubious, but I would say that, whenever it's frequent enough for him to go to a doctor, it should be given due attention.
I'll continue with you, Dr. Choudhuri, and we'll talk a little bit more about the risk factors. So who are the people who are more likely to get into this, into, these symptoms or into actual reflux disease?
So two things, let me tell you. It's a combination of constitutional factors and lifestyle factors. On the constitutional side, if a person is obese or is overweight, he is more prone. Number two is that sometimes if there has been a strong family history, कि daddy को भी डकार आते थे और जलन होता था, that there is a genetic component which has now come up. Number three is if he's a smoker or a tobacco consumer. Actually, very interestingly, nicotine reduces the pressure of the valve, or makes the valve loose. So there is more reflux. And people who, consume alcohol in significant amounts, especially for dinner. So alcohol also loosens that valve. And there are, of course, quite a few medications which can loosen the valve, which I think Dr. Puri will talk about. On the lifestyle front, apart from the obesity and other things that I mentioned, tobacco and alcohol, it's basically, if we are eating fried food, that is, fat in any form, be it chole bhature or be it, puri sabji, or for that matter, cheese and pizzas, it can worsen reflux because it reduces the valve pressure. Spicy food, typically, I think many of our Indian cuisines are very tasty, but they give you problems at night. Excess of tea, coffee, that is caffeine, askar doodh wali chai, I have seen often can cause a bit of that. Chocolates. In fact, I'm surprised that a lot of people eat chocolates at night before going to bed. Cocoa actually reduces the pressure in the valve, so it makes the valve loose. So, and I mentioned tobacco and alcohol. So these are the common ones. And one more I just should not omit, aerated drinks.
So coming to you, Dr. Puri, would you add to that? That's a very nice explanation of all the risk factors. But what about, as an endocrinologist, what about obesity as a risk factor too? Do you think, Dr. Puri, obesity is also a risk factor for this?
Yes, sir. It's a very important risk factor because there is almost a direct correlation of obesity with the GERD. The odds ratio of getting GERD are much higher in obese versus non-obese. And if you go towards morbid obesity, then it becomes, most of them would have the symptoms, not only the symptoms, but also the endoscopic lesions, they would be there. So obesity is a major, and we tell the patients that, they must do a sincere effort, a conscious effort to lose weight if they want to get rid of the medicines. Otherwise, it's going to be a lifetime consumption of these medicines.
Talking of medicines, there are also medications that actually do cause increase in acid reflux or provoke acid reflux. And Dr. Choudhuri listed all the common risk factors. We talked about obesity, but there are also things that we use as treatments or patients pop them themselves that can increase the risk of acidity and reflux. Would you want to explain that a little bit?
Yes, because any medicine, there are medicines whose direct effect or indirect effect would be on the valve, on the lower esophageal sphincter. So any medicine which has an effect that it loosens, makes it more open, so to say, and the lower esophageal sphincter, reduces the pressure of the lower esophageal sphincter, that is going to cause reflux. And I would, the top of my list would be bronchodilators. All the patients who are, bronchodilators, at one time aminophylline used to be deriphyllin, aminophylline. They were the drugs that most of these patients would be taking. Of course, we moved on, but even with the salbutamols, it is still very much there. May not be as much as aminophylline and deriphyllin. So that is number one in my list. Then for osteoporosis, I think the endocrinologists are very fond of using the alendronate, and that causes severe reflux. I'm not sure how many cases it is actually indicated, but it's almost a fad that everybody wants. They want common drugs. They want to go in for these fancy drugs, and definitely it has a very severe effects on the LES and the resultant GERD. Another drug which has definite, it opens up the LES is sildenafil. Now, not only for sexual enhancement. It's also used very commonly for in post-transplant, for liver transplant, for primary pulmonary hypertension. So it is being used in various conditions. And not to forget drugs like antihypertensive, like nifedipine. Now, nifedipine has such a relaxing effect on this that we use this in the treatment of achalasia cardia. And lastly, some antibiotics. And if I had to tick one, then it'd probably be the tetracycline group. So by far, this is the common list of drugs that would cause, or not cause, aggravate GERD. So both cause and aggravation of GERD would occur in these patients.
Quite an important list, a long list of common drugs. Also, I suppose, painkillers and drugs used for lowering fever. These days, people are getting all kinds of, COVID or viral fevers or headaches. And commonly, people just pop their painkiller without thinking too much, the non-steroidal anti-inflammatory agents. You want to make it?
Most of the NSAIDs actually cause gastritis. The effect on the esophagus is much less as compared to the gastritis. So they would cause erosions in the stomach. They would cause erosions in the duodenum.
So is the case with steroids, with the corticosteroids?
That's right.
Gastritis again.
Yes.
So I think I'll continue with you, Dr. Puri. Now, okay, you've told us all the causes. Dr. Choudhuri has discussed that. Now, how do we investigate? Do you require any tests, or it is just a clinical diagnosis?
And that's a very relevant question, because I think a good clinician would initially make this as a clinical diagnosis. He wouldn't require any fancy tests. So, and I would say the SOP, the standard operating procedure, is if you suspect a patient to have GERD, then you give him the drugs for GERD, and you can wait for 2 weeks, maybe wait for another total of 4 weeks, and see how he responds. And if he has a dramatic response, say he says my symptoms are 90% less, then no further tests are required. You would just go. Of course, you would go through the risk factors that we have just discussed a short while ago, and tell him that how he can modify his diet, how he can cut down on his weight, probably increase his physical activity, etc., etc. And therefore, no. But what about the patients who continue to have symptoms? Then you would definitely need to investigate. And as of now, there are two standard investigations that are useful in making this diagnosis where it is in doubt. And I think Dr. Choudhuri referred to that in his initial message that he was giving. Endoscopy is the primary investigation because, as they say, seeing is believing. So you see the ulcers, you see the linear ulcers, you see the circumferential ulcers, and you know that this patient has got. But sometimes we land up in a quandary, and we're really wondering why this patient has nocturnal symptoms. In those difficult cases, which I would put 5% or 10%, you would need a more advanced test, which is referred to as a 24-hour pH metry. And briefly, we just put an electrode. It's a very thin electrode, very thin, almost the size of thinner than the cable of your iPhone charger or your cell phone charger. It's thinner than that. That's placed, and it's placed in the esophagus under endoscopic guidance. And this has the sensor that it'll pick up the changes in pH. I won't go into details on that.
Thank you, Dr. Puri. Dr. Choudhuri, I'll come to you now. Can this untreated acid reflux disease or GERD, can it lead to something more sinister, more dangerous, or it is just a symptom and you treat it with medication? We'll talk about the medication towards the end. Or it can actually have consequences that are dangerous for you.
So one is, if the food which is refluxed or acid which is refluxed, if it goes into the wrong place, so getting up in the middle of the night with choking or with asthmatic attacks is bad enough. And especially if suppose somebody has got already a heart problem and, it happens at 3 in the night, it's a very unpleasant situation, can be risky to life. More important is that if you have ulcers in the food pipe, they can sometimes bleed. And therefore, one of the common causes for bleeding from the stomach or intestine is because of these ulcers. In fact, there is a condition in which the valve that we talked about, between the food pipe and the stomach, it gets so loose and the stomach gets pulled up. It's called hiatus hernia. And that is usually often linked with fairly significant reflux, and ulcers can form in that hiatus hernia. It's one of the very common causes for bleeding. The other thing is that if these ulcers remain untreated, then in some patients over a long period of time, they can produce narrowing of the food pipe called a stricture. So that part becomes badly scarred. Worst is that there is a condition which is called Barrett's esophagus. So if for a long time, if suppose the ulcer is formed and the acid keeps bathing those ulcers, there's a change which happens in the mucosa, which is called Barrett's esophagus. And Barrett's esophagus, many people believe, is one of the precursors of cancer of the lower end of the esophagus. So these are the common complications that are known. So overall, world over, there has been an increase in the rates of lower esophageal cancer, and that has been linked epidemiologically to the increased prevalence or increased occurrence of GERD across the world. So these are some of the things to be worried about or concerned about, or at least one should know about it. It's not that every person who gets an occasional reflux needs to think that he has developed esophageal cancer, but yes, it's beyond just a symptom, and you need to sometimes be a little sure that you're not progressing down the slippery slope.
So how do we prevent this, Dr. Choudhuri? Short of taking medications, I mean, what can a person do in their lifestyle to really prevent development of these symptoms and this condition?
Broadly, clinically, there are two types of refluxes. One is called as a nocturnal refluxer. That is, where mainly reflux occurs at night. And that is usually linked to the fact that at night when the body is horizontal, so the effect of gravity is gone. And therefore, if the valve is loose, the acid tends to climb up into the food pipe. The other is a daytime refluxer or, at any time refluxer. What one needs to do is, first and foremost, you can't correct your genes that you have inherited. So you can modify some of the other factors. So if you're overweight, please lose weight. Very important. Number two, if you're a nocturnal refluxer, make sure that your dinner is at least 3 to 4 hours before you go to bed. Number three, if you are fond of alcohol, and if you take your alcohol, obviously people take alcohol in the evenings. So I think for people who are nocturnal refluxers, they would do very well to, stop taking their alcohol and having late dinners. Number four, if you're a smoker, certainly quit smoking. It is not just for reflux, but it will anyway add to your life expectancy and make your life healthy. Number five, modify your diet. So, I think the usual type of fried and spicy foods that we have and citric foods that we have, we need to really change our ways of eating.
So, Dr. Choudhuri ने बहुत अच्छे से हमको बताई बात कि हमको अपना वजन कम करना चाहिए. रात को अगर हम खाना खाते हैं और हमको एसिडिटी की टेंडेंसी है, रिफ्लक्स की टेंडेंसी है, तो खाने और सोने में गैप होना चाहिए. 3 घंटे का तो कम से कम होना चाहिए. हमें अपना हेड एंड, अपना तकिए का साइड थोड़ा ऊंचा रखना चाहिए, जिससे कि वो खाना वापस ना आ सके हमारे उसमें. और साथ में स्पाइसी फूड जो हम अक्सर लोगों को पसंद होता है, विशेषकर इस देश में, तो स्पाइसी फूड को कम रखना चाहिए. अल्कोहल नेवर हेल्प एनीबडी मच, तो अल्कोहल को बहुत कम मात्रा में रखें या उसको भी सोने के काफी पहले रखें, गैप रखें. ऑब्वियसली स्मोकिंग के तो हम नुकसान हर प्रोग्राम में गिनाते आ रहे हैं, हर स्पेशलिस्ट ने बताया, डिफरेंट कार्डियोलॉजिस्ट, पल्मोनोलॉजिस्ट, सबने यही बोला है. तो इस बीमारी में भी स्मोकिंग नुकसान करती है. ये सारे प्रिकॉशंस अगर हम रखेंगे तो बहुत सारे सिम्टम्स ऐसे ही खत्म हो जाएंगे. वैसा नहीं है, एक टाइम था जबकि जिनको ऐसी बीमारी होती थी उनको बिल्कुल ही वैसा खाना खाना पड़ता था जिसमें कुछ नमक तेल कुछ नहीं हो. ऐसा नहीं है, लेकिन बेसिक प्रिकॉशन से हम इस बीमारी को, अपने इस सिम्टम को कंट्रोल कर सकते हैं. Dr. Puri, last point to you. We are nearing the end. The last point is that आजकल जैसे हर चीज में हम लोग दवाई ले लेते हैं, लोग कोविड के लिए एजिथ्रोमाइसिन बिना डॉक्टर से पूछे भी शुरू कर देते हैं. तो ये तो ऐसी चीज है कि एसिडिटी है और कुछ है, डिस्कम्फर्ट है. हर व्यक्ति जो है वो अपनी कोई दवाई ऐसे, people are just popping pills like crazy. They are picking them up at counters, and everyone knows, and despite all the regulations, we can get most of these drugs over the counter. Dr. Puri, where do you place this use of medication? Is it good because it does help symptoms, or is it overused? How do you balance that out?
Okay, so I think we discussed this point. Agar aapko intermittent symptoms ho rahe hain once in a month or something, then maybe you're better off with just taking on-demand therapy.
Yeah.
So we would just have on-demand therapy. That means you take it for 2 or 3 days when the symptoms subside, or you anticipate you're going out of station for a wedding. You're likely to be eating spicy food and having alcohol, smoking, etc., etc. So you can start your PPIs in that. But most patients, specifically those who are obese, who have other risk factors, they would require long-term PPI therapy. And therefore, I think the primary drug that is now being used is what comes under the category of PPIs, or proton pump inhibitors. Everybody has heard the name omeprazole, pantoprazole. So these are common drugs that we are using. They have to be given for fairly long time because it is also thought that if the reflux occurs unabated, then as Dr. Choudhuri said, it can lead to a condition called Barrett's esophagus. It can cause strictures. So these patients who continue to smoke, who are overweight, they are the candidates whom we would say that, well, you require long-term treatment. Otherwise, these complications can occur. But there are also other drugs which are, almost free of side effects. And this is what has come in the last few years. This is the concept of raft. So the medicine that you take, it will float on the food that you take. It forms a raft, an impervious raft that will not allow the acid. So this is whether you take alginate or any other common drugs that are come. So this is there in the market, and they are definitely for symptomatic relief. They are definitely very, very helpful. They are generally free of side effects, minimum side effects, and they can be taken three times a day, 4 times a day. So these would be the two that I would think.
So thank you, Dr. Puri. The concern, however, still is that people may self-prescribe these medications. We don't encourage that. We don't encourage self-prescription of proton pump inhibitors. We do encourage some control over the duration unless the specialist feels that they have to go for a long period. Don't pop them endlessly yourself, because there are reports of issues with calcium absorption, with long-term kidney effects. So every medicine, as we have emphasized in this program again and again, has to be taken under medical advice and not popped on your own, because if taken injudiciously and for prolonged periods, unsupervised, it can result in certain long-term effects, including these commonly used drugs, the omeprazole, pantoprazole, rabeprazole, as you just heard. Thank you very much, gentlemen. This was really very nice. And you touched on a very common and important area, and I'm sure our viewers will be benefited. Thank you very much. And thank you, viewers, for being with us. Thank you, viewers, for being with us.